Hello everyone, we are here to discuss the questions of your grand test, and this is your grand test 181 dermatology, which we are just about to begin with. What happens to be my question number 1 here is actually question 194 in your GT, and so subsequently are the other questions. So this is question number 194 in your GT. When such big questions come in front of you, it becomes slightly intimidating, especially in an exam where the time that you have is very less, let alone give it to reading such long questions. But do not get bothered by such questions. Take a pen in your hand. Just underline the important points that they'll tell you. There'll be barely 4-5 important words in this question which are important. Let's go through this together. A dentist notices that his 39-year-old patient has scattered white reticulated areas on the buccal mucosa. Have been present for a year. Then she has purple pruritic papules on the elbow. Biopsy shows band-like infiltrate at the dermoepidermal junction, along with degeneration of basal keratinocytes. So yes, this is what you read in the question. Fairly easy one, I am sure. All of you can get to this answer. Tell me the diagnosis. Only then will we go through these options. See, this is a very smart question. It's not asking you the diagnosis. It's not even asking you the treatment or management. It is asking you the finer details of this disease. To know that, first tell me the diagnosis. Patient probably has such kind of a lesion in the oral mucosa. As the question describes, an area of fine reticulate whitish plaque on the buccal mucosa. If it was on the tongue, would have looked like this. Along with that, she has purple pruritic polygonal papules on the body, which may look like this. And then it also gives you the histopath, which is band-like dermal inflammation and degeneration of the basement membrane. So it's giving you a finding of the mucosa along with skin, along with histopath. And all these descriptions are classical. Classical of the disease, which is Lichen planus. Correct? Did you all get it? I'm sure you did. When we come to the mucosal findings of Lichen planus, the classic lesion is this. It is a whitish to violaceous plaque with overlying reticulate stria, which are also called as Wickham's stria. Clear to everyone? These could either be asymptomatic, the patient doesn't know they exist, or there could be symptoms like burning sensation on eating hot, spicy foods. Okay? Clear? Every point here is important. Violaceous plaque, Wickham's stria, symptoms on eating hot, spicy meals. Now, for your purpose, there are two major types. One is the reticular type and the other is the erosive variant. Reticular type is the most common variant. Mostly asymptomatic. Erosive has symptoms and there is a risk of SCC in the future. In this image, what you see is the reticular type. Okay, it just has whitish stria or reticular stria on the surface. But in this image, if you notice the center has raw erythematous erosion in the center. This is your erosive type of oral LP. Here symptoms are quite severe, plus, as I already discussed, a risk of squamous cell carcinoma happening in the future. Although the risk is low, it's less than 5%, nevertheless, it is there. Clear to everyone? Coming to the cutaneous lesions of lichen planus. The cutaneous lesions, as you can notice, are classically like this: purple pruritic polygonal planar papules of lichen planus. You must have heard of the 5 P's of LP. That is what you have to remember. Then the site are the acral areas and the flexures mainly. Main symptom is itching. Intense itching, classical of lichen planus. Alright? Then what else does LP infect or affect, as we can see? The LP also affects the nail. Nail classic lesion is pterygium, which is wing shaped extension of the proximal nail fold onto the nail bed, leading to irreversible, permanent loss of nail. Clear to everyone? Irreversible, permanent loss of nail. Other findings: nail plate thinning and longitudinal ridging. Out of this is the most important question. This is the pathonomic nail finding. In this question, in one of the options, it could also have been this. Pterygium is the pathognomic finding. So you have to remember. What else does LP affect? LP also affects the hair, scalp, causing lichen planus pilaris, which is lichen planus of the hair, leading to irreversible scarring, alopecia, presenting as violaceous patch associated with hair loss. Clear to everyone? So we've discussed the findings of LP in mucosa, skin, hair and nail. Lichen planus at one site, either of these 4, increases the predilection of lichen planus happening at other site. So in this patient, it is oral mucosa and skin. In some other patient, it may be a combined hair and skin, hair and mucosa, or a combination with the nails. So please remember, in every patient, one site, other side can be involved. The question can also rotate, revolve around all of these findings. Okay? Now, important to discuss is the histopath of lichen planus. In this question also, they have given you the histopath findings. The histopath findings are very typically seen in this image here. Okay? I don't know how much you can identify from here, but just look at the rete ridges, which are normally like this. And here, these are like this. So this is called as sawtoothing of the rete. This image also shows something of that sort. When we discuss the histopath, we will always go from top to bottom so that you remember it well. What are the layers top to bottom? Stratum corneum, granulosum, spinosum, stratum basale, then we have a basement membrane, rete, and the dermis. This is how we go from top to the bottom. In stratum corneum, what is happening? There is a hyperkeratosis, which means increased thickness of stratum corneum. In granular, there is hypergranulosis, which is wedge shaped. In stratum spinosum, we have acanthosis. This is undergoing vacuolization. So you have vacuolization of basal cells. Apart from this, you see necrotic keratinocytes here, which are also called as civet bodies, right? Basement membrane undergoes liquefactive degeneration. Rete is sawtooth. Dermis, band-like lymphocytic inflammation. All right, these are the classic features of lichen planus. And to tell you something, a question involving the histopath of lichen planus is seen almost every alternate year in one of the exams. Histopath of psoriasis and lichen planus are the most important questions that you get in dermatology here. And every point that I've written here is a question in itself. Hypergranulosis, classical, because LP is the classical cause of increased thickness of the granular layer. Acanthosis, yes, here this is also wedge shaped. Then vacuolization of basal layer along with necrotic keratinocytes. This, and this. Every point is a double Q, means important. Then, if this is 1, this is 2, and this is 3, then 1 plus 2 plus 3 is together called as interface dermatitis. What is the meaning of interface? Interface is where two layers, two media interact. In the skin, where the epidermis and the dermis meet, that is the interface. So the lowermost layer of the epidermis the basement membrane, uppermost dermis. Together, when it is involved, it is called as interface dermatitis. Okay? 1 and 2 are the pathognomic HPE of LP. If it is asked which is the most characteristic feature of the histopath of lichen planus, then it is this and this. If only one of them is there in the answer, if it is like a single choice question, then 1 is more than 2. So the answer is vacuolization of basal cells. Some other points that you have to remember here are this. One is pigment incontinence. When the basement membrane gets damaged, basal layers get damaged, the melanin which was there in the basal layers drops into the dermis. The way you have urine incontinence, stool incontinence, similarly here the pigment is dropping down on its own into the dermis, called as pigment incontinence. Important question. Second thing that you have to remember is the Max Joseph space or cleft. What happens is, in the histopath, when the interface is damaged, there may be some clear spaces which appear in the histopath. This is just an artifact. This is not happening in reality. It is a histopathological artifact seen during the slide tissue preparation, called as Max Joseph space or Max Joseph cleft. This is also important. Clear to you? Entire HP on the same slide. Now, if you look at the histopath again, see here. This is your acanthosis. Then you see the granular layer, hypergranulosis, sawtoothing of the rete, see here in this portion of the slide. Do you see that there is no continuity of the basement membrane? It is empty. The way it is running here, there is a break in the continuity of the basement membrane. This is where your BM is liquefacted degeneration. The basal cells are vacuolized and you see some dead keratinocytes as purple dots in the epidermis. Don't worry, histopath of LP classically may not come in your exam for you to identify, but you should still know these finer points. Look for the continuity of the epidermis. Look for damage to the cells as seen here in this part and this part. Along with that, see these lymphocytic inflammate in the dermis here. Another image that I have is this one. See, here also you see this hypergranulosis, increased prominence of the purple granular layer. Then you have increased thickness of the stratum spinosum, which is acanthosis, sawtoothing of the rete. And in this area, if you notice, basement membrane is not continuous. There is a vacuolization of basal cells and this inflammate which is running like a band from here to here. This is your band-like lymphocytic infiltrate in the dermis. Can you just picturize what we wrote in the text in this diagram? You will be able to understand it quite well. Clear? Good. Now we discuss the treatment. LP, you should know, can resolve spontaneously over 2 to 3 years. When it heals leaving behind pigmentation. If you have to give treatment, treatment can be oral or topical. In topical, you generally have topical steroids and TCI, which is topical calcineurin inhibitors, like tacrolimus. In the oral, you have oral steroids, and you have cyclosporin, you have hydroxychloroquine, and you have dapsone. Okay, these are the treatments for LP. Some other therapies like phototherapy with narrow band UVB may also be used. Very important question. LP can be self-resolving. Time period question. Leaving behind pigmentation is asked. Then topical calcineurin inhibitors, narrowband UVB therapy. These are all the important questions in the treatment of lichen planus. So what have we discussed? We have discussed the various clinical manifestations, diagnosis with the histopath, and the treatment. Clear to all? So, coming back to the question, now you tell me what is the right answer. Squamous cell carcinoma likely to develop in skin lesions? No, it only develops in the erosive oral LP. You have SLE? No. You should stop taking all medications. It is not mentioned that the patient is taking any medications. No. Lesions will resolve over time? Yes. LP, as we discussed, is self-resolving. So clear to everyone? So, question number 195 in your GT. A patient from Delhi presented with ulcerative lesion on the face after being bitten by an insect. What is the probable diagnosis? Is allergic dermatitis caused by the bite of an insect? No. Scabies is an infestation, multiple lesions all over the body, not caused by the bite. Urticaria may be a manifestation of an insect bite, but it doesn't look like this image. So even if you don't know the answer, you don't identify it like this, but ruling out these simpler options gets you to this. This is a case of cutaneous leishmaniasis, classical case of cutaneous leishmaniasis. What is it now? When we talk about cutaneous leishmaniasis, it is of 3 types. Cutaneous leishmaniasis, mucocutaneous leishmaniasis, and post-Kala-Azar dermal leishmaniasis. Mucocutaneous means involving skin and the mucosa, and a separate entity called as post-Kala-Azar dermal leishmaniasis. Okay? Now, coming to cutaneous leishmaniasis. This is also called as the Delhi boil, which is why the question mentions the patient being a resident of Delhi. It is also called as oriental sore or a chick lero boil. That's another name of this. Most of these are actually zoonotic disorders transmitted by the bite of a animal to the human. In this case, the bite is of the vector called as sandfly, scientific name being Phlebotomus. Then what is the insect here? It is leishmania, which is actually a intracellular parasite living in the macrophages in the skin. So what actually happens is, this is the promastigote form living in the sandfly. When it bites, gets transferred to the blood, develops into the amastigote form, leading to the infection in the skin. This is your cutaneous leishmaniasis, also called by these names. Now, how does it manifest clinically? This can either manifest as the rural type or the urban type. The rural type is the moist type, in which there is an ulcer on the skin. In the urban type, which is the dry type, it is generally a chronic, non-ulcerating nodule. Clear? Clear to everyone? Ulcer, when it happens, generally happens like this. This is the ulcer here, and these are the edges and the margins which are sloping. Because of this, it is also called as volcano sign. Clear? Please remember, this is an important question. Volcano sign is seen in. If you come back to the image shown in this question, then you will notice that here also on the side view, this will look like a volcano. So with the same image, they can also ask you what sign is being manifest in this image. Answer would be volcano sign, right? What are the sites? Because this is caused by an insect bite, it will generally be on the exposed sites like the face, arms and the legs. How will you diagnose? Diagnosis will be 1. Clinical examination. Then you do a Giemsa stain of the biopsy that will show you LD bodies which are intracellular amastigotes in the macrophages. But the gold standard for diagnosis, gold standard is PCR. This is the gold standard of the diagnosis. Clear to everyone? Yes? How do you treat? Most of the lesions are generally self-resolving. If at all you need to give treatment, treatment of choice are SSBs, which is sodium stibogluconate, pentavalent antimony. This is. Other than this, we can also give amphotericin, oral drug, miltefosine. Clear to everyone? Question किस पे आता है? Question इस पे आता है, इस पे आता है और इस पे. Clear? Will you all remember this? Yes. Then one more thing that you need to remember is the cause of mucocutaneous leishmaniasis. The important thing that you need to remember about mucocutaneous leishmaniasis, what is asked here is the cause. The most important cause for this is Leishmania brasiliensis. Okay, this is what you have to remember here. Treatment is the same as we discussed before. Then the thing that you need to remember about PKDL is that there may be a history of fever, hepatomegaly, and 1 to 3 years later patient has skin lesions, which could be papules and nodules. Clear? So this is the other two important leishmaniasis that you need to remember. Question is this, question is this. Treatment options remain the same. I hope it is clear to you from here. So if we come back to the question, but typical image, exposed site, face, resident of Delhi, bitten by an insect, culminates into a final diagnosis of cutaneous leishmaniasis. If I were the doctor, I would leave the patient like this. This will mostly resolve on its own. Moving on to the next question. A 25-year-old man complains of recurrent episodes of flexural eczema. This is an adult. Flexural eczema, urticaria, skin infections, and abdominal complaints on taking seafood. What is the diagnosis? What is the question here tell you? Let us note down the points that the question is telling you. Tells us this is an adult patient with flexural eczema. This is the primary complaint. Then he has a history of atopy, means an allergic tendency, which is your contact urticaria plus seafood allergy. Cramps and diarrhea upon taking seafood means the patient is suffering from a food allergy. Other than that, he has a tendency to recurrent skin infections. These are the points that the question gives us. Very classical, very typical, cannot go wrong with it. The answer is atopic dermatitis. Clear to everyone? Just pick up the relevant points from the question. Together, only diagnosis possible is this. Let us read about atopic dermatitis. This is a chronic, relapsing, remitting inflammation of skin. 3 points are important here. One is immune. Dysregulation. Then the other point is a genetic tendency. And third point is environment. Immune dysregulation means this is a Th2 dominant response. Generally in the body it's a Th1 dominant immune response. However, in these patients it is Th2 dominant. What comes with Th2 dominance? Interleukin 4, interleukin 5 and eosinophils. Genetic tendency means there is a chance of family history here. Third thing is environmental allergens, food allergens, airborne allergens, pollen, dirt, dust, mites, all of these can cause atopic dermatitis. However, the most important point is barrier dysfunction. There is a deficiency of filaggrin. If you remember, filaggrin is present in the keratohyaline granules of the stratum granulosum in the epidermis. Helps in keratinization, forming the impermeable barrier of the stratum corneum. If filaggrin is deficient, steroids and ceramides, which are the oils, they are deficient. Stratum corneum barrier will be defective. Host allergens, environmental allergens will enter the skin, cause an inflammation. So, the most important point here is barrier function, hence the most important question, deficiency of filaggrin. What chromosome? Chromosome 1 has the gene for this. So, please remember chromosome 1, filaggrin, Th2 dominance, these interleukins. Clear to everyone? Yes? Very good. Now, it has 3 phases. One is the infantile phase, then you have the juvenile or the childhood phase, and then you have the adult phase. Infantile generally starts around 6 months to 2 years of age. You have acute red VP eczema seen on the face, scalp and the extensors. Juvenile is generally any time during the childhood. Here you see subacute reddish brown scaly lesions present on both flexures and extensors. In adult form, the lesions are more chronic and lichenified, seen on the flexures. Clear to everyone? What are the points to remember here? Here you have acute eczema, face, extensor. Subacute, both. Chronic, flexural. Clear? Yes? Now, a patient comes to me. How will I make the diagnosis? The diagnosis is by the Hannifin and Rajka criteria. You need not know the criteria in detail, but the essential most feature that is required for diagnosis is itching. Whatever be the stage of the lesion, whatever be the age of the patient, Itching is the most essential criteria. Without itching, you cannot make a diagnosis of atopic dermatitis. Then patient may have personal or family history of atopy. Atopy means a tendency to allergy. This could be urticaria, then it could be allergic rhinitis, allergic conjunctivitis, food allergy, asthma, either in the patient or the mother, father or sibling. So it could be a personal history, family history of atopy. Then typical morphology and distribution of the lesions. Like we've just seen, depending on the age, what is the type and the distribution of the lesion. Then the early onset. These are the 4 major criteria. You need to have at least 3 of these. Apart from this, you have 22 minor criteria. You need not to remember them, just remember these important points. Okay? Then how do you do the scoring of disease severity? SCORAD index. How do you treat the patient? One is identify an allergen, cessation of exposure to the allergen. In case the patient has recurrent skin infections, treat the infections. Proper emollients. Moisturizers are the most important component of treatment. When it comes to medicines, medicines could be both topical and oral. Topical may you have topical steroids, topical calcineurin inhibitors like tacrolimus, oral steroids, cyclosporin, azathioprine, then narrowband UVB. Okay, most important in the treatment of this. क्वेश्चन किस पे आता है? क्वेश्चन आपको इस पे आता है, इस पे आता है, और इस पे आता है. अब आपको एक नया जो क्वेश्चन आएगा वो आपको आएगा व्हाट आर दी बायोलॉजिक्स दैट आर यूज्ड हियर. Biologics that are used here. Biologics that are used are dupilumab, which is anti-interleukin 4 mainly, that you have to remember. Okay, this was recently approved for treatment of moderate to severe atopic dermatitis. Then another biologic that you have here is mepolizumab. Okay, is the spelling clear? Mepolizumab. These are important new questions that can come from this disease. I just have a few images that we can see here. See, this is infantile AD. Acute red VP lesions on the face, scalp and extensors of the baby. How do you remember this extensor flexure, extensor flexure? Remember it like this. When the baby starts to crawl, the extensors come in contact with the floor. So allergens can affect this area first. So remember, infantile AD affects the extensors. Okay? Remember it from here. And face, very typical, most of the questions will say that the baby has cheek eczema. Classical of infantile AD. Childhood, both extensors and flexures. Subacute, reddish brown lesions. The baby had red lesions. These are red, acute eczema. Here, these are reddish brown, subacute eczema. Okay? Then we come to adult. Here, lichenification, flexures. The adult moves around in the air, allergens come and get deposited in the flexures. So the eczema classically affects the flexures. This is how you can remember the distribution pattern. Clear to everyone? So we come back to the question. What is the answer here? The answer here is atopic dermatitis. If we discuss what is seborrheic dermatitis will have yellowish, greasy scales on the eczema. And the sites will be classically seborrheic sites. What are the seborrheic sites? Patient will have lesions here, then in the scalp, sides of the nose, nasolabial fold, mental crease, preauricular, postauricular. These will be the classic sites where seborrheic dermatitis will affect the patient. Nothing of this sort is there in the question. So this is out. Airborne contact dermatitis, generally seen in the farmers. Exposed sites will be affected, like the face, arms and legs. Again, nothing of that sort in the question. And nummular dermatitis is just another name for a type of eczema. It is more of a morphology, round eczema lesions, seen generally in middle-aged adults, most commonly on the leg. Okay? So even by exclusion, the answer is this. Moving on to the next question. Question number 4. This is again an image-based question, and get aside, see the image, read the text, give me the answer. What is the question asking you? This is a 8-year-old boy with a cardiac condition, with reddish papules developing all over the body and severe pain in hand and feet. Even if it was just a text-based question, we can come to the diagnosis. Images are only helping us here. Let us write down what is there in the question. It's a child. Okay? The lesions started appearing at birth. So this is probably a congenital disorder. Then he has a cardiac involvement. It is a deposition disorder causing hypertrophic obstructive cardiomyopathy. Then the patient has skin lesions, which are red papules, and the patient has a nerve involvement in the form of acroparesthesias, means pain in the hand and the feet. This is the information that I gather from the text. Now I come to the image. In the image, I see that the lesions are present on the trunk, on the mucosa, and the conjunctiva. So there are cutaneous lesions and mucosal lesions, mucosa being oral and ocular. Reddish papules. Together, the only condition with this kind of a diagnosis is Fabry's disease. Okay? You may not remember the skin manifestation, but the constellation of symptoms here together make the diagnosis as Fabry's disease. I know you cannot identify angiokeratoma from these images. It is very difficult for you to identify. Most of the students at the undergraduate level have not seen an angiokeratoma case. So don't get bothered by the image in such questions. If it is a difficult image like this one, they will give you all the hint in the text itself which is happening here. So identify here, image is only an add-on. If I show you the image clearly, the close-up will look something like this. These are actually reddish brown papules. They have a skin plus a blood vessel component. The skin is thickened, capillaries within it are enlarged. Together it is called as a angiokeratoma. So the skin lesion characteristically is angiokeratoma. It is all right if you don't identify it from the trunk or the mucosa. It's a very difficult identification per se, but just remember where it is commonly found. It may be a solitary manifestation, but when combined with these systemic features, Fabry's is the diagnosis. This is just an image giving you the salient features of Fabry disease, all of which are important. All of these are questions. किस पे आते हैं questions? Angiokeratoma, as you've just seen. Then the enzyme alpha galactosidase, leading to accumulation of trihexosides, which are the ceramide trihexosides. So this is actually a storage disorder. Fabry's disease, leading to cardiovascular disease, acroparesthesia, and skin manifestation. Clear to all? Please remember this flowchart. This is a important question. Fabry's disease. Clear to all? Yes? So coming back to the question here, the answer is this. If we discuss what xeroderma pigmentosa is, had it been a case of XP, then also the disease would start in the child, not necessarily at birth, maybe a few years down the line. There will be xerosis plus pigmentation, as the name suggests. Pigmentation would be in the form of freckles. Then there will be eye manifestation in the form of conjunctivitis, keratitis, and eye ulcers. Apart from that, there will be increased risk of SCC, BCC, and melanoma here, and the child generally dies by the age of 20 years due to these cutaneous malignancies. Now, what is important? This, and this. Clear to everyone? Another thing to remember about XP is that the inheritance is autosomal recessive. So this will generally be seen in consanguineous marriages because it is autosomal recessive inheritance. Other thing to remember is the defect. The defect is nucleotide excision repair defect. NER, very, very important. Due to which sun exposure leads to mutations in the DNA. Accumulation of these mutations over a period of time increases the risk of skin malignancies, which is the ultimate cause of death in these patients. Okay? Pseudoxanthoma elasticum is actually a defect of the extracellular matrix, leading to classical features like plucked chicken appearance of the neck, angioid streaks in the retina, and cardiovascular disorders like aortic dissection because of the damage to the matrix of the aorta. Tuberous sclerosis, genodermatosis, you get adenoma sebaceum, ash leaf macules, shagreen patch, ependymomas, cortical tubers, autosomal dominant inheritance. So even by exclusion, this is your answer. Clear to everyone? Moving on to the next question, question number 5, Ritter's disease. They have asked a synonym. You may know if I ask you from the actual term. Ritter's is another name for it. So that makes it slightly difficult. Can you tell me what that diagnosis is? What is Ritter's disease? Ritter's disease is this. Staphylococcal scalded skin syndrome, S4, aka Ritter's disease. What is it actually? What is it? SSS. This is the hematogenous dissemination of toxin which causes generalized peeling of skin, seen in babies, where you may get a localized focus of Staphylococcus aureus infection. This could be otitis externa, folliculitis, okay, a localized focus of the infection which produces the toxin which then gets hematogenously disseminated, leading to this. You have to know the mechanism of action of toxin. This cleaves desmoglein 1. So this cleaves desmoglein 1. Where is this seen? Pemphigus foliaceus, leading to cleft in the skin, separation of the cell layer, leading to peeling of skin. So you have only skin involvement here. There is no mucosa. That is important. No mucosa. Treatment of choice, IV, vancomycin. Extremely important question. What did they ask you? They ask you this, 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 okay, and culture from the skin will be negative because the skin is not infected. It is only the toxin that is coming and acting on the skin. Positive culture will only be from the ear if it is otitis externa or elsewhere where you have the bacteria. The rest of the other body is only the toxin. So culture will be negative. Please remember this. See the image here? This is the image which is generally used in your exams. This is a baby who has generalized peeling of the skin. Okay, very, very important as image-based question also. Next question. A patient came with an area of hair loss over the scalp. So this is an area of hair loss. You see something positive in the Woods lamp. Identify the disorder. For this you need to know what are the things that are positive in the Woods lamp, because this can also cause hair loss, this can also cause hair loss, and this can also cause hair loss. P. versicolor is out because it doesn't cause any alopecia. So one of these three is the answer here. Now, what is Woods lamp? Woods lamp is something like this. Here is the lesion, here is the doctor, and this is your Woods lamp. These are two tube lights which are generating UV light. Then this is a special glass made of barium silicate with 9% nickel oxide. Critical wavelength 365 nanometer. What is it? You go in a dark room, switch on the lamp, light falls on the lesion reflects the light, and you see it through the glass. Whatever is the type of color that comes from there helps you identify the disorder. Some important Woods lamp positivity are seen in Tinea, capitis, the ectothrix type, which is caused by the microsporum species. You will get a pale green fluorescence. Then you see this in another fungal infection, which is P. versicolor. Here you see pale yellow fluorescence. Then there is another infection caused by Corynebacteria minutissimum called erythrasma. This is coral pink. Then you see this in porphyrias. The teeth, urine, they fluorescence reddish pink. Okay, these are some of the important Woods lamp positivities. Other causes like vitiligo or ash leaf macules may say exaggerated fluorescence only. There may not be any color, you will just see it more white as compared to the surrounding skin. All of these are questions. You have to remember all of them. Okay? Good. So now we come to this area of hair loss with positive Woods lamp. The answer is Tinea capitis. What are the uses of positive Woods lamp in Tinea capitis? 1, it helps you make a diagnosis. 2, It can also be used for screening. Like if a school girl comes to me with a case of Tinea capitis, I will go to her classroom, put Wood's lamp on all the girls, boys also, identify a subclinical case of Tinea capitis where apparent hair loss may not have happened till now. So this is also used for screening, which is a question, and diagnosis, monitoring the treatment if my treatment is helping. Clear? I hope you all get it. If it was alopecia areata, how would it look like? Alopecia areata would look like a patch which is well defined alopecia with exclamation mark hair. It will not be Wood's lamp positive. Telogen effluvium will be a global hair loss. Global hair loss. There is no patchiness happening here. It is hair loss from the entire scalp. Causes of which may be depending on whether it is acute telogen effluvium or chronic telogen effluvium. P. versicolor, multiple hyperpigmented scaly macules on the upper chest, upper back, giving pale yellow fluorescence on Wood's lamp. Even by exclusion, we come to this diagnosis. This is just to tell you the type of Tinea capitis. Here, this is the grey patch Tinea capitis, which is Wood's lamp positive, caused by Microsporum species. None of the others will be positive. Clear to all? Yes? Thank you. All the best for your exam.